I am delighted to introduce the first session of the day. The purpose of this session is to identify the challenges that over-testing and over-diagnosis pose for healthcare, including an exploration of the impact of the increased use of AI in healthcare and its environmental impact. Over-testing and over-diagnosis is of crucial importance in the NHS and other healthcare systems. The overuse of tests or the delivery of tests which have no clear benefit can subject patients to discomfort and extend periods in hospital. Overuse is also a waste of finite healthcare resources and can have a significant environmental impact. This session will address some of these challenges of over-testing in healthcare, as well as exploring some potential avenues for consideration in future care delivery. We have an incredible lineup of speakers, including Professor Natalie Armstrong, who is Professor of Healthcare Improvement Research at the University of Leicester, Dr. Charlotte Augst, an independent social sector consultant, and Professor Florence Doo, Director of Innovation at the University of Maryland Medical Intelligent Imaging Centre. Following these presentations, we will have a panel session to discuss the important issues raised across the session talks. We are really eager to hear your questions. Please feel free to send any questions you have while you're listening to the talks. You don't need to wait until the end. And I'm now delighted to hand over to our first speaker, Professor Natalie Armstrong.
I'm Natalie Armstrong, a Professor of Healthcare Improvement Research at the University of Leicester. And I'm going to be talking about the challenges of avoiding overuse by not doing, or to put it another way, why it can be hard to do less rather than more in healthcare. So we know that there is increasing concern around too much medicine. There are terms like overuse, overdiagnosis, overtreatment that are increasingly being used. And we know that they're increasingly being recognised as a significant problem in healthcare. So just as some examples, we have things like reports from the OECD, which focus on tackling or the need to tackle wasteful spending on health. We have initiatives like the BMJ's Too Much Medicine. And we have international campaigns like the Choosing Wisely initiative, which seek to promote conversations between patients and clinicians about whether particular interventions are really necessary. So I'm interested in how we can try and ensure just enough medicine and get that balance between the potential for underuse and overuse, because I see both as potential problems in healthcare quality. I started working in this area through a Health Foundation Improvement Science Fellowship a few years back. And I like to use this picture of a bowl of porridge when I talk about this issue, because to me it makes the point that just enough will probably vary person by person and context by context. If we think of Goldilocks and the Three Bears, getting the right porridge was important for Goldilocks, but what suited Daddy Bear and Mummy Bear was not at all right for her. So there's a lot of interest in the drivers and possible solutions for overuse. And I think it's fair to say that a fair bit of it focuses on individual behaviour change. But as a social scientist by background, I'm more interested in how individuals think, understand and behave in complex social systems or structures, some of which is deliberately, consciously made decisions, but some of which isn't. This is one example of work seeking to map the potential drivers and possible solutions to overuse. This one's specifically focused on overdiagnosis. And as you can see, this focuses at various levels, starting from patients and the public in the middle and working out through various layers to culture and wider society. I think some of the solutions that are posed down the right-hand side of the diagram here are quite broad in nature, and I'm not sure how achievable some of them would really be in practice. What's often talked about in relation to just enough medicine is the need for really effective translation of evidence into practice. and in particular navigating the potential gulf between the population-based evidence that's available and the individual patient or situation. Sociological analysis of the medical profession has long paid attention to the exercise of autonomy or discretion as a key element characterising the work of professionals, what Elliot Friedson has talked about as the zone of discretion. And this space for discretion is on the face of it quite promising and appears potentially very compatible with efforts to reduce overuse by choosing not to do something. But things might not be that simple. The growth of the Audit Society is argued to have led to the development of regulatory cultures and new forms of bureaucracy within medicine that prioritise particular forms of codified knowledge, such that being a healthcare professional relies more on the production and use of these encoded and formal forms of knowledge rather than the more tacit knowledge achieved or acquired through experience, arguably that which would be most useful in seeking to avoid overuse. We know, for example, that healthcare professionals can worry about the potential for complaints from patients or the risk of litigation or of questions being asked about their professional practice, and that this can mean they might be more cautious and defensive in their approach and end up doing things just in case. And here, of course, we're getting into the potential for blame. So Christopher Hood defines blame as the act of attributing something bad or wrong to some person or entity, involving some harm or loss having taken place, or at least the potential for it, as well as crucially an attribution of agency. And though he emphasises that blame is not always bad, he does argue that faced with external demands for accountability, blame avoidance can become a dominant preoccupation. The ability to exercise discretion or the freedom to decide what should be done in a particular situation may also be constrained by a sense of how things are done around here. The institutional logics perspective proposes that large-scale organisational social structures like healthcare tend to be characterised by distinctive sets of assumptions, values, beliefs, and practices, all of which offer repertoires to individuals that constrain their behaviours, their choices, and the ways in which they understand things and understand what's possible. A couple of quick examples. So this is work led by Caroline Cupit, focusing particularly on cardiovascular risk scoring in the context of the NHS Health Check. It showed how healthcare professionals used knowledge of evidence-based risk reduction to frame patients' queries about taking preventative medication, in this case statins, as barriers to be overcome, rather than a potentially legitimate request to not do something. It highlighted the processes through which healthcare professionals came to overrule patients' concerns and uncertainties about taking these preventative medications, such that some patients reported feeling unable to openly discuss their preferences and needs within healthcare consultations. And I think what's really important here is that the analysis points not to deficiencies of individual professionals who lack expertise or inclination to adequately share decisions with patients, but more to the ways in which the healthcare professionals' work is institutionally orientated towards performance measures which will demonstrate that they are effectively tackling the burden of cardiovascular disease. This is work led by Fawn Harrod Hyde, looking at so-called inappropriate transfers of care home residents to hospital. And through interviews and ethnographic observation within care homes, the work showed how care home staff often felt very torn about whether a transfer for a resident to hospital would be in the resident's best interests. And they weighed up a number of possible risks and benefits. And what was interesting was that often staff felt that a transfer wouldn't be in the residents' best interests, but they also felt that it was risky not to do that because it was available as an option. And the things that they were concerned about included things like the potential for reputational damage to the care home and also potential questions about their own individual conduct. So I've been interested in thinking sociologically about overuse and in particular not doing as a way of avoiding it. In this paper, I sought to demonstrate that a sociological perspective on overdiagnosis and overtreatment can recast them as issues that must be understood as a consequence of the organisational, financial and cultural attributes of healthcare systems, not just a product of individual actions. I've drawn on this work by Susie Scott, A Sociology of Nothing, and it's the accomplishment of doing nothing that I'm particularly interested in. As in the quote, Scott's argument is that nothing is not just a passively endured condition, but rather that nothing must be accomplished or done. Scott draws on the distinction between acts of commission or omission, the former being a deliberate decision not to do something, the latter occurring more by passive neglect or failure. So an act of commission or a deliberate decision not to may be counter to what is normatively expected and therefore make the non-doer potentially socially conspicuous. Their non-action may need to be explained and accounted for. So what might we need to do to better support clinicians and their patients to do less rather than more? Bearing in mind that a commonly cited driver of overuse is healthcare professionals' fear of litigation and their subsequent defensive practice, we perhaps need to think about how decisions not to can effectively be captured and translated into forms of encoded knowledge able to service the relevant logics at play within healthcare organisations. And this is likely to be particularly important when decisions appear to run counter to good clinical practice and/or to specific guidelines, but which are felt to be appropriate in those particular circumstances. And while guidelines are intended to be guidelines, not tramlines, we know many professionals are nervous about being seen to deviate from these in the care that they give. Many of the factors that drive overuse will not be resolved by an emphasis on individual behaviour change alone. For both patients and clinicians, the things that people end up doing are not necessarily the result of discrete decisions, but often result from all kinds of norms and expectations that are socially embedded. To do nothing arguably requires a certain amount of work to be done. Things must be accounted for, appropriately documented in notes, for example, to create a clear record of what has and hasn't happened and how and why and with whose agreement. Luckily, I have an excellent PhD student who's looking at this topic at the moment in the context of primary care, funded through a fellowship from this institute. Claire's interviewing a range of primary care clinicians about decisions not to do and how they approach documenting and accounting for those decisions. So lots of what I've just talked about and lots more besides can be found in our contribution to this Institute's Elements series, and I hope you'll take a look at that if this is an area of interest for you. These are the references for the literature that I've cited, and thank you very much for listening.
Good morning. I'm going to talk to you about the sorry subject of overtreatment and overintervention at the end of life. And towards the end of my talk, I'm going to talk about the need for us to practice medicine as if we were mortals. To start off with, very briefly, it is really undisputed that end-of-life care in the UK is miserable and it's not improving. What you can find here are reports from the last 10 years or so, looking into people's experiences at the end of their lives and documenting really a litany of failings of care coordination, poor symptom control, and really heartbreakingly, people feeling utterly lonely and abandoned at the end of their lives. The most recent one is the Marie Curie one there, the yellow one, which confirms that these important data points have really not shifted consistently in the last decade. Compassion in Dying is a small organisation I've done a little bit of work with this year, and they analysed 5,000 calls and emails to the information line to understand what was going on. And they found that we miss so many opportunities to speak with people and listen to what they actually want at the end of their lives, and then to actually enact those priorities. You can see a quote here from someone who talks about the death of their loved one, but shockingly also, you can see the outcomes of a large YouGov poll, which show that 1 in 4 people who were with someone recently who died believe that that person received treatment they would have not wanted. And a very large majority of people, 8 out of 10, say very clearly they would prioritize quality over quantity at the end of their lives. And it is very clear from all of this that the system is based on a blatant disregard of people's wishes. So what we have really is a burning platform. In my view, this does not work for people or the system. For people, there's an overwhelming lack of respect for their priorities and wishes, which leads to unwanted treatment. We miss opportunities to have conversations about what people want. And we also miss opportunities to put in place good community-based support. And what this leads to, and these numbers are lifted from the very recent Marie Curie report, is that people they spoke to who were recently with someone who was in the last stage of their lives said that 1 in 3 of those people had uncontrolled, overwhelming pain or breathlessness. And as if that wasn't heartbreaking enough, they also describe that over a third of people dying in hospital had no one with them. So we are piling on unwanted intensive treatment and interventions, but we are abandoning the most basic human need for companionship at the end of life. It doesn't work for the system either. When you look at the proportion of hospital beds that are occupied by someone in the last 12 months of their life, if you look at the amount of unplanned admissions, and just again, some nuggets from the Marie Curie report, 15% of people dying in hospital die within 24 hours of arrival. Only about a third of them had a conversation with a healthcare professional about what they want at the end of their lives. And families and loved ones believe that in about 1 in 4 cases, the person dying was even unaware of the fact that they were about to die. All of this is by definition really low value care. So what do we need to do? It's my firm belief that we need culture change on 2 levels, both within the health system and in the community. First up, we need to maximize opportunities for understanding what people want and documenting those wishes in a way that is really easy and accessible. I do believe the NHS app might be able to play a role in this. Health checks and annual reviews should be brought to this. And really, to wire this into the system, I would argue we need an advanced care planning guarantee so that everyone in the second half of their lives is offered an opportunity to have a conversation about what they want and to document the outcome of that conversation. We need to support and challenge healthcare professionals to transition from active treatment to comfort care. And again, to just move away from hand-wringing towards actually wiring this into the system, I do believe we should introduce a duty of candor so that if a healthcare professional believes you have acquired a terminal illness and your days are now numbered, that they have a duty to offer you a conversation about this. And finally, and it often boils down to money, We need to align the money flows with what we actually want to achieve. We need to take money out of hospital and put it into community care, largely 24-hour community nursing and access to decent pain relief in the community. There's some good work going on by Macmillan about how some of this could be achieved through social finance. We need to stop worrying about a theoretical infringement of people's right to ongoing intensive treatment and start addressing the very real, tangible ways in which we violate people's rights to appropriate, tender care at the end of their lives. We have to practice medicine as if we were all going to die.
Hi, everyone. My name is Florence Doo, and today I'll be talking about sustainable diagnosis, or the environmental impact of imaging AI. So let's get started. Here are my disclosures. I'm not going to read them to you, but one thing I just wanted to highlight at the bottom is that all discussed items are for educational purposes only, with no specific product being endorsed. So as a radiologist, how do I think about sustainability? One is that sustainability is not just about philanthropy. It's a necessary investment in the future. And radiology AI is an important consideration for that sustainable future. What does that mean? Well, the World Health Organization says that climate change is the single biggest health threat facing humanity. And they asked in the New England Journal of Medicine whether healthcare's climate impact is mission critical or extra credit. And I'd like to argue that it's mission critical. What that means is that in the US, healthcare contributes nearly 10% of admissions, with imaging playing a significant role. So when I think about right patient, getting the right diagnosis for the right treatment at the right price, all of that care and that care journey, right, contributes to sustainability. So that intersection of how I use AI as a physician, how I deliver imaging care, and my impact on the climate all impacts my ability to sustainably deliver care. Here's an article that we wrote together called Environmental Sustainability and AI in Radiology, which we're going to go over very briefly in these next few minutes. First, I'd like to think about the negative environmental impact in these three categories: AI model development and deployment, data storage, and energy source choices. As you may know, in the US, the number of FDA-cleared medical devices are many, and over 75% of them are in radiology, this blue bar here. In the Journal of American College of Radiology, JACR, in 2020, they asked, how are ACR members using AI? At that time, 33% of people were using AI, with 20% thinking they were going to use it in the next 5 years, which has proven to be pretty accurate because the most recent 2023 data does show that 50% of radiologists do use some form of AI in practice today. This may look like lung nodule screening, as you can see here on this CT, or PE detection, for example, on this other CT. And as we think about using AI at scale with quantitative, perhaps screening, we do need to think about the informatics ecosystem that's supporting that usage. For example, these data sources, the modalities of X-ray, CT, ultrasound, MRI, needing to plug into the PACS and VNA or the EMR system, perhaps being on the cloud or on-prem, and all of that needing to be accessed by the multiple users of different clinical experts, researchers, patients, and operations admin, and also outside of that with regulatory experts like the FDA, other vendors, and other societies that are thinking about registries, for example. And all of that is associated with even more cost, with already expensive diagnoses and diagnostic equipment. All of that needs to be factored in. This other thing, just briefly to talk about some of the research we were doing, was thinking about how large language models are being used now today as well. So we took a chest radiograph data set and used that prompt across different sizes of these models and different types of models: Llama 2 and Vicuna 1.5, 7, 13, 70 billion, over here 7 and 13. Looked at the accuracy of those models in doing this one task of labeling chest radiographs and thinking about the energy that's consumed and the efficiency ratio, and thinking about how much energy is actually being used as we're making these queries just for medical purposes. So it's really important to think about, as I was doing that research, right, how is that reported in our research and towards our patients? Thinking about what kinds of benchmarks are available in our abstracts, our papers, and in public policy. Is there such a thing, for example, as a radiology eco-label? We do know that we have green building certifications, Energy Guides, Energy Star. Is there a way we can create new ways of thinking about how we're being sustainable in our healthcare journey? in both the design, the hardware lifecycle, and the transparency of that service. So another area I want to think about beyond the negative environmental impacts is using AI as a positive lever to augment sustainability. So for example, in this category, we'll briefly look at scanners, image acquisition, clinical decision support tools, and opportunistic screening. Briefly, you can see here that there's MRI images on the left that have been reduced in scan time using AI from 1 minute and 59 seconds to 1 minute and 18. And over here on PET CTs is reducing the scan duration from 24 minutes to 6 minutes, which also improves the patient experience of being in these scanners and also reducing the amount of burden on the healthcare system with trying to not be able to accommodate all the patients that need the screening possible. But on the other end, it does increase the workload of the radiologist. Other ways we can think about is the quality checks that might go into getting your image. What happens if you need to come back for a repeat image because it wasn't done right the first time, right? And in mammography, this happens quite often. And you might see that the first technologist and second technologist may have done fine with their 2 patients, but that third patient, that quality was not done well. So if you could get immediate feedback, you could take that image right away and reduce the need to reschedule that patient. You can see here that they've even graded using AI, the quality of the image, and you can even use a dashboard to see which technologists may be performing better or worse, and actually using this as an educational moment to improve the quality of care and improve that technologist's workflow, for example. So thinking about that dashboard just a little bit more is, can we consider which MRs, which CTs, which ultrasounds may be getting more study volume to kind of understand how we're distributing care geographically inside the hospital system and outside of it? Also, financial analysis, how much time are these operational, and are patients able to access that care when they need it? And for the healthcare system, are they maximizing the time of that use of that scanner? Another way to think about this is also contrast waste and contamination. So when we do IV contrast, that goes straight into the water supply and is something that we should think about. So with artificial intelligence, we can reduce the dose of contrast and take something that is usually difficult to see. So for example, the middle part of that image, low dose conventional screening, is very grainy. And sometimes you can improve that image and use low dose images and acquire that with AI. And you can see that that is equally or even better than usual low dose images. And this last piece, just very briefly, is thinking about the patient and radiology workforce scheduling. So you can see that in this MRI diagram, that there are 4 different scanners with 4 different colors, from yellow to pink. And there's certain white spot areas, gaps, where you could schedule a patient. And another thing is protocoling with remote technologists. So at this main hospital in the center here, you might have expert technologists doing really high-level, difficult care. And these other more remote hospitals may not have that same access. And the difficulty was initially being able to get that technologist's expertise, or even the technologist to be able to go out to these other sites. But you could actually do this remotely up in the cloud and kind of remotely protocol and make that care accessible to more patients across a larger geographic region. So I hope you can see just from this very brief glimpse that artificial intelligence really will impact the sustainability of care, but also improves our ability to provide sustainable care in this other realm. It is a balancing act between these 2 pieces. And one last thing I do want to highlight is that this really hits on all dimensions of sustainability. What I want us to think about is that when we think about care, from the individual to the interpersonal to the community to societal to global, that this is really individual health, family health, community health, population health, and then planetary health. And when we bring in these other pieces, which we're very familiar with the sociocultural environment, the biological environment, the built environment, we don't always think about the digital environment and how people are experiencing this new technological wave. Are they literate? Do they have accessibility to cell phones and computers? Do they have understandings with societal changes? And are there laws and policies that are adapting to this new world? So all of these things I'd like to highlight together is that sustainability is not just about philanthropy again, it's a necessary investment in the future. And this fabric of radiology and imaging, diagnosis, and radiology AI is an important consideration for that sustainable future, to understand how we're diagnosing patients either in over or under testing and diagnosis. So my homework to all of us today is to brainstorm more ideas to improve sustainability of imaging care delivery. And let's collaborate on papers and projects to make the world a better place. I'd like to end on this quote by Amanda Gorman, who said, "Above all, I dare you to do good so that the world might be great. Thank you so much for listening to me today.
I would like to start by saying thank you to our speakers for all those fantastic talks. As we move to our discussion, I would like to introduce two other panel members. The first is Mr. Mark Oates, who's a patient representative with experience of acute hospitalisation, and Dr. Zoe Fritz, who is a Wellcome Fellow in Society and Ethics here at this institute and a consultant in acute medicine in Cambridge. So I'm going to kick off with the first question, and I would like to come to you, Zoe. The concepts of over-testing and over-diagnosis can be difficult to understand and navigate. From your experience, how can we communicate about these concepts with patients and families effectively?
It's a great question. So I think it's about making sure that when we start a conversation with the patient, we have engaged with them or their families and made sure we know it is what they want, what is most important to them, so that there isn't a sense that we're trying to ration what we're doing or that we're trying to meter it out, but that we're actually trying to make sure that we are doing the investigations that line up with them or the treatments that might be of benefit to them. And so if I take an example from my own practice, we often see frail elderly patients who come in, for example, with a low sodium or a fall or something. And it's very easy as doctors to start on a diagnostic odyssey of trying to find out why do they have a low sodium, or and keep them on a monitor for 3 days because they've had a fall. Whereas if you say to the patient, what's most important to you, they might just say, I just want to get home as fast as possible and I want to stop feeling sick. And then you can do those things and you can explain. I think we have to be honest with patients and say, look, there are all kinds of tests we could do to try and find out why you have that low sodium, but that would require you being in hospital for several days, and I want to make sure I'm doing what's right to you. So I think in summary, it's not about explicitly using the terms over diagnosis or over treatment, although I do think we need to talk about those societally. But I think on an individual level, it's about making sure we know what's most important to the patient and prioritizing those things.
Thanks, Zoe. Mark, I'm really interested in your perspective on this from, a patient perspective, I suppose.
Thank you. I think just picking up on what Zoe said, the first thing is that begin the conversation. So I don't think in my experience, I ever really felt that somebody was beginning the conversation with me about over-testing or over-diagnosis. I think that clear communication piece is essential. I think the being cognizant of the patient in front of you in terms of their background, so the language that is used and the like. Sometimes, I certainly found that my wife, when I was in hospital, didn't always understand some of the terms that were being used. So I think that is super important. And then the final point that Zoe mentioned, that some of the concepts that Flo's talk around societal and the environment is not something that was even slightly on my radar before today. And they are pieces that I would consider, especially some of the pieces around spending less time being tested. So the piece around using AI for scans, and the piece around scheduling slots so that as a patient, I don't have to wait until whatever time in the future. So that would be my answer. But the first thing, to begin that conversation and be cognizant of who you are talking to and match language with them. Does that answer your question, Jo?
It does. Thank you, Mark. Natalie, do you have any thoughts on this?
Yeah, thanks, Jo. I completely agree with what Zoe and Mark have said. I think, so a lot of the work that I've done over the years has been around population-based screening. And I think there's potentially an interesting difference between discussions on an ongoing basis with a patient and their families for, a condition or something that's being investigated or managed. And then kind of the offers that the healthcare system feels it's appropriate to make around kind of preventative interventions like population-based screening, where I think there is very often a narrative of wanting things to be available. I'm thinking of the examples that we had a few years ago when there was the debate about breast cancer screening. We're obviously having that discussion now in relation to testing for prostate cancer based on kind of Chris Hoy's diagnosis. And I think I think it's particularly interesting in those kinds of contexts to try and bring in perhaps some of the evidence about the balance of possible harms and possible benefits of screening for particular things in particular populations. And I think what's very obvious at the moment through the prostate cancer narrative is the weight to which people want to put on the risk of overdiagnosis and overtreatment, and how important that is or isn't to various people. So I think it's interesting to kind of think across the piece about those different contexts in which we're trying to communicate about these issues and what will work in different situations.
Thank you. I'm going to move on to a question from the chat, and I'm going to come to you, Florence, for this one. And it's about the environmental impacts of AI within the healthcare setting. Do you think enough attention is being paid to this in the context of so much AI development within the healthcare setting?
Yes, thank you so much for that question. So yes and no, right? I think that because these tend to be very separate in different realms, people always ask me, how are you doing sustainability research as a radiologist, right? And in healthcare, I think those things don't usually overlap. But one of the things is that a lot of places now, because of large language models, are thinking about how to generate energy, how to do that sustainably. So you can think that Microsoft is building their own nuclear reactors, right? They're trying to invest in that in the US. Where people are building these plants, people are thinking of toxic waste centers. They know that they should not be building toxic waste centers next to their neighborhoods, but don't think about data centers using a lot of water and using potable water for their cooling. And another area is also thinking about where those data centers are located. A lot of these places are obviously closer to certain city centers that may be closer to where you work, where you live and play. And I think all of those issues are not well understood on a policy level, especially since those realms are not typically things that healthcare folks think about. But we, as radiologists, do have a lot of machinery as well that we purchase. And a lot of that life cycle is not considered, and the impact on our local communities we don't understand ourselves, and then we have difficulty communicating forward. And there's great work actually being done mostly in Europe because of the way that they think more about the societal changes. I think you all have a slightly better system than the US focused ones, where we have more individualistic hospital centers. And so there's places like Denmark thinking about how much water use. So for example, about 500 milliliters of water are used each time that you query a ChatGPT instance. So you can only imagine all the AI tools I showed, unfortunately, are using lots of water, lots of energy, and are killing the environment.
Thank you for that. Charlotte, would you like to come in on that point?
Yeah, I find it really interesting, just listening, thinking through the point I tried to make and the point Flo was making there about the parallels, really, that maybe we are going through some sort of painful transition as society, trying to understand that the planet imposes limits on what we can feasibly achieve, that permanent growth, even more use, using every last drop of oil, using every last tree, felling every last tree, will exhaust the planet. And that there is a real strong parallel, which I find quite moving to think about. Realizing that human life is limited, we have a lifespan, and that we need to practice medicine cognizant of this, of the limits that our planet imposes and of the limits our lifespan imposes, and how that might help us reframe medicine in a way that is just less exhausting. Because I think what we're doing right now, particularly for people who acquire a number of conditions as they move through life, is we're exhausting them with more and more demands, with huge treatment burdens, and particularly at the end of life, I think it leads to real cruelty. But we're also exhausting the health system. We're exhausting the people working in the health system who are tired and overwhelmed. And I do wonder whether just reflecting and maybe even meditating on those limits that our life and our planet by necessity impose on what we can achieve will help free us up, focus on the things that add real value. And real value, let's say at the end of life, is making pain relief available reliably 24/7 at the weekend at home, rather than rushing someone off in an ambulance to have another test done. So I think it could help us really do human and planet-sized healthcare.
Thank you. Mark, would you like to come in on that one?
Yeah, I do. In part because I think the conversation is important to have around end of life and that point in terms of over treatment. And if I was in that space, I wouldn't want to be, you know, treated until I'm in the coffin kind of thing. But I'm also thinking about patients who are earlier, who are my age, a bit older, a bit younger, where for me, the most important thing was, and not from a litigation point of view, was I don't want anything to be missed. So do whatever tests you have to do and then keep going so that you don't miss something, so that then you, the doctor or the nurse, can treat me for that condition. And selfishly, at that point in time, I probably care slightly less about some of these other concerns, because sometimes what's missed for me is that conversation of, we have done the appropriate amount of tests, you know, we'd have got 99.5% of patients, you know, and it's just not worth it for you to keep going. So for me, at that point, that's the priority. So I think just that I'm keen that there's balance between, it's not just about the patients who are end of life, but people who potentially are going to live half their life. I think Charlotte mentioned having a conversation in the second half of life. I'm a bit worried that I'm actually in that group now.
Thanks, Mark. Zoe, I'm going to come to you next. You've done lots of work around the Respect tool here in this institute. I would like to hear a little more about that tool and what you think the potential is for advanced care planning, and perhaps in particular the Respect process to help ensure patients get the treatment they would potentially benefit from.
Yeah, delighted to talk about Respect. So it stands for Recommended Summary Plan for Emergency Care and Treatment. So it's a summary tool that is used to help facilitate conversations between a patient or those close to them and a clinician. I mean, it can be for anyone. So those approaching the end of life, those who have chronic conditions, or those who just feel strongly about treatments that they would or wouldn't want to receive. I mean, the idea is it's all about shared understanding. So that conversation that I mentioned at the beginning about talking about overtreatment, not about the concept of overtreatment, about what's important to you. The Respect process is about shared understanding of what the current condition is of the patient, shared understanding of what's most important to the patient, so what health outcomes they value, what health outcomes they fear, and then critically and relevant to this, a shared understanding of which treatments are likely to get them to the places that they want, and that that we shouldn't use because they're likely to get them to the places they wouldn't want. So for example, someone who says, I don't want a lingering death, or someone who says what's most important to me is to be at home if at all possible, those kinds of things can be documented, and then they can guide clinicians in those situations. It's almost impossible to predict every single possible scenario, as Charlotte will agree, I'm sure. I can see her nodding, I hope that means. So having a whole bunch of tick boxes, would you want this or this or this in all these different situations, is really tricky. But being able to document in a readily recognized way what's most important to the patient, we've got some evidence that it is helpful both in improving the conversations, but in making sure patients get the treatments they want. And actually, back to Natalie's talk, it's really helpful, for example, for patients in care homes in terms of conveyance to hospital. So if you have documentation that someone's had a conversation with a patient about what they would or wouldn't want, in what context they want to go to hospital, then it not only provides the patient and their families with something, but it actually helps the care home and the ambulance clinicians in a scenario where someone might be sick. But then you can say, well, actually, they don't really want to go to hospital. What we need to do is make sure that they're in their care home with the people that they want to be with, so long as we can manage their symptoms. Obviously, if someone falls and fractures their hip and you can't deal with it in a care home, then clearly you take them into hospital. But it allows that prioritization of treatment to happen. So I'd be interested to know, particularly whether Charlotte and Natalie think Respect, which is used in an awful lot of England now, in half of Scotland, and I think it's being brought across Northern Ireland, whether they think that might be a helpful tool in achieving this.
Natalie, would you like to come in on the wider point and the Respect tool?
Yeah, absolutely. And it is definitely something that came up in Fawn and Howard Hyde's work that I mentioned in my talk. And I think I agree with what Zoe has said there about the potential for these kinds of tools to be really useful. I think what Fawn found from her work was, sometimes the staff within care homes not feeling that what has sort of been documented through those kinds of processes were sufficiently robust enough for them to feel safe that this is absolutely, I am going to make the right decision and this will support me. I mean, I'm sure that is something that can be addressed. But I think what they also talked a little bit was about when things start to get quite challenging, it's not uncommon for family members to start to ask for something different. Ask for something different from what's kind of been documented, and that can feel quite a difficult tension to manage as well. But again, it comes back to doing these things well in practice. It's not always as easy as you might think, and I'm sure Zoe's not suggesting it is.
Thank you. We've got just a couple of minutes left, so I'm going to ask one final question, and this is to Florence. You spoke about AI and the use of AI within healthcare. What would you like to encourage patients to do to support the ideas that you've put forward today? Is there anything that patients can contribute to this?
Yes, thank you so much for this great conversation. I've learned a lot from everyone here. And I think specifically when you're asking about patients, I think all of us are patients, right? And we bring this perspective into our care, is thinking about what do we want for ourselves? What do we want for our loved ones and our society? And part of it is people ask about AI tools now. I think one of the surprises I get when I talk to audiences is that they don't realize that 50% of radiologists are using artificial intelligence. In the US, we do not have a system or to actually report that we're using it. So one of the things you can do is ask if your hospital system is using artificial intelligence, and in what way in your care. Are they advising your diagnosis? Are they using it to improve your scheduling, for example? And kind of bring these technologies to places that you otherwise may not get, right? People may not think that it's important to kind of optimize their scheduling and kind of get people in earlier, even though they might want it. They may not be aware of certain technologies being available. So I think part of this is really leveling the playing field and making things available to people when they need it. Again, right patient at the right time for the right price and everything. So thank you so much for inviting me to this talk today. It's been really great.